Excellent. Welcome to this webinar brought to you jointly by Qure and Hardian Health. We have an international panel with us today, and we are going to be discussing RSNA 2022, all of the key trends, the developments, with a specific focus on the AI market. It's my great pleasure to be able to bring to you today three expert panelists. We have one just joining as we speak. Here she is, Ella A Kazerooni. Hi Ella, how are you? I will start by letting the panelists just briefly introduce themselves. So tell us your name, where you work, and how you're involved in AI. We'll start with you, Peter.
Just checking my microphone is on. Hi, good afternoon, or good evening, or good morning, depending upon where in the world you are. I'm Peter Strouhal, radiologist by background, practicing consultant for 21 years nearly. 15 years or so experience in the independent healthcare sector at sort of director level, and now working for an imaging-based company covering UK and Northern Europe. We're called Alliance Medical. We're part of Life Healthcare, which is a multinational company that has a parent company in South Africa. But for the UK bit, we are an imaging-based company, mobile and static facilities, CT, MRI, PET CT, and I'm the medical director.
Thank you so much, Peter. We'll move on to you, Walter. You're over in America. Tell us a bit about yourself and how you got into AI.
Yeah, hi, good morning from, nearby Duke University in North Carolina. I am Walter Wiggins, a practicing neuroradiologist and spine interventionalist at Duke University Medical Center, where I also serve as the clinical director of the Duke Center for AI and Radiology. So in my role there, I lead our AI efforts more on the side of clinical integration, testing, monitoring of tools that we have in deployment, and help out my co-director who's more on the development side of things.
Brilliant. Thank you so much, Walter. And yeah, no worries. And Ella, do you want to introduce yourself briefly? Welcome to the show.
Hi, thanks for having me. Welcome. My name is Ella Kazerooni. I am a cardiothoracic radiologist at the University of Michigan, and I am responsible for our diagnostic portfolio and our medical group practice, which includes radiology. One of those important things is the integration of advanced technologies, I think what we're going to be talking about today. And as a cardiothoracic radiologist, I've been particularly involved in the implementation of tools that can help thoracic radiologists in detection, characterizing, and measuring disease.
Brilliant. Excellent to have you here. So we're going to dive straight in. We're talking about RSNA. Look, I'm wearing my RSNA jacket, especially for it. For those in the audience who don't know what RSNA is, it's the Radiological Society of North America. It's America's largest organization for radiologists, the education of radiologists, the training. But it also hosts this global international conference every year in Chicago at the end of November. It's freezing cold. But we spend most of our time in McCormick Place, which is a vast venue. And you have vendors there from every walk of life within the radiology sector, whole MRI scans and CT scanners and all the interventional radiology equipment is there, as well as educational sessions, loads of content, academic presentations, keynote speakers, and AI as well. We're going to be talking a bit about how AI trended this year at RSNA, what were the key market movers and shakers, and what's been happening in the AI sector. So I guess what we'll start with is either you or all of you can jump in as and when you want to with answers. I guess my first question is, this was the first RSNA back where we seem to be heading back to near pre-pandemic levels of attendance. So how did that affect the enthusiasm and the energy of this year's conference?
I think the energy and enthusiasm was palpable. It was, even last year when there was a virtual meeting, there were some people at the meeting, but it was still pretty quiet. The uptick in attendance, the number of people that were available to talk to, colleagues, peers, industry, it was quite a hot vibe, and it was a great and exciting place to be around this year.
Yeah, it felt like a bit of a reunion, I think, of sorts, Walter.
Absolutely, absolutely. I was there last year I remember, 2018, 2019 levels where I think we hit our peak attendance for this meeting, and it seems like we were trending back in that direction in a big way. Last year, there were days at the meeting where it just felt like a ghost town. It felt like there were more vendors there than there were attendees, and this year it felt like that the in-person attendance was back. And I just saw the numbers released yesterday. I think they had total registrants of 38,000. So including virtual attendees, I think we're getting back to a normal sized RSNA meeting.
Yeah, it's hard to really explain to people the vastness of this conference. And Peter, you were saying you were doing 12,000 steps a day, just walking around between meetings. Is that right?
Yeah, I think as I said before, that was probably bad planning in that we had one meeting in North Hall, then one meeting in South Hall, and we never seemed to have a consecutive meeting in the same hall. It was just how the diary worked. But yeah, we were averaging 12,500 steps because we were there very much for the sort of exhibition space. When I go for Alliance with the Business, I subscribe to the virtual event and then do my CME online for the next few months. But in person, for us, it's very much the exhibitors in the exhibition halls and the vendors, if you like. And yeah, it kind of felt back to normal, as you said, Walter. I was there last year in person, and it just was weird. Just the there's a coffee shop between the North and South halls. If you've been, you'll know the one I mean. There's normally a queue that comes all the way out and snakes around. The fact that at one point I walked straight in and I was second in the queue was surreal last year. This year was back to the long queues. But actually those queues, I was bumping into people I hadn't seen for however long, and the queue was a whole nother networking event. And that was the thing I found, was the enthusiasm that people seem to have to be back face to face, sort of properly in that venue and in that event, was quite something.
Yeah,
I like the word that you use, reunion. I had many colleagues from across the world come who had not been in several years, and it was really great to see them and be able to just talk about what their life experience has been through these last several years, and where they are, of course, with their radiology practice.
Yeah, and actually, it feels like there are almost 3 conferences happening at the same time. You have the academic conference where people come and learn, they get their CME points, their accreditations, they can do things like the Deep Learning Lab, which we'll talk about with you, Walter. They can attend lectures and find out the latest research. That's one part. Then you have all the vendors, the exhibits, so people are trying to find out what are the new trends, what's new on market, what's cool, what's happening, in terms of the tech that they can buy. And then you have the socializing in the evening, which, depending on your diary, can get very, very busy. There are several parties a night can happen. So I don't know how anybody does the whole conference in its entirety. I think it's almost impossible, isn't it?
Definitely the kind of meeting you have to rest up for after you've come back.
Yeah. You get the post-RSNA colds, don't you? Yeah.
Working on.
Well, I think we're all recovered. Yeah, you got one right now. Okay.
Yeah.
So, attendance was up, energy was up. What were the big key trends? If you could think of, maybe you come back and say, I took 2-3 takeaways from RSNA this year. What's different this year in radiology in general? What are the key things that are happening? Ella, do you want to start?
I think one of the things that was really palpable, and it's part of what we're going to discuss today, was how AI and adoption in practice, from operational aspects to assistance with clinical interpretation and workflow, has become a dominant factor on the industry floor. In prior years, there was certainly an AI presence, but it was much smaller. And we didn't even just see it on the industry floor. We saw it integrated into the sessions. We saw discussions on the ethics of artificial intelligence. So I think the discussion is getting broader. And that's really important to move the conversation forward. And even I think the RSNA to that point has developed a new artificial imaging certificate that people can take to help learn and understand more about AI, which is moving the field forward. And it was really palpable. I spent so much time on the floor trying to hit as many as possible, and it was almost impossible because there was that much more this year.
Yeah. And Walter, you were running the deep learning lab. Was that busy?
Yeah. So we had, I think, 16 sessions scheduled throughout the meeting in the deep learning lab, which was held in the learning center where the posters and the resident lounge are typically held. And I tried to drop by as many of the sessions as I could, being the course director, and every session I went to, with only one or two exceptions, was literally overflowing. We had people standing outside the windows. There were only 60 seats in the classroom. We had people standing outside the windows, peering in, trying to get a glimpse of what was happening because there was just not enough seats. And I talked to Brad Erickson from Mayo, whose group presented a few sessions there, and he said, this is great. Just keep them wanting more. And so I think it was a big success this year, certainly an increase in the attendance over last year, which was the first year we had expanded it to more than just 4 or 5 sessions. And so I think it's really heading in a good direction. Some of the things that we showcased this year that I think were a little bit different were we started really getting into the details of how AI is made, how the sausage is made, so to speak. And there were 2 separate sessions that were just on data processing and curation, which we did last year, but were heavily attended this year. Just talking about how do you even do the data work to get ready to train an AI model, because that, if you talk to data scientists, they'll tell you it's at least 90% of the effort of creating an AI tool. And so I thought it was great that we were highlighting that a little more this year. We had some of the prior winners of the Kaggle RSNA competitions, the machine learning challenges that the RSNA is co-sponsored with Kaggle, who were presenting. Their meetings were exceptionally well attended, or their talks were exceptionally well attended. And I think people really just enjoyed an opportunity to have an interactive session where they can play around with some code or some data and try to get a feel for how this stuff really works.
I mean, that's fantastic. 16 completely packed sessions, and radiologists still wanting more. We're not seeing quite the same enthusiasm in the UK, are we, Peter? But what were your take-homes from travelling over the ponds and seeing what's happening?
We're not. You're right. We're not seeing the same level of enthusiasm. I think some of it is ultimately a recognition that we have NHS IT challenges, and
that's very polite way.
That let's be blunt, right? I mean that's the issue, isn't it? That people talk about connectivity and having platforms and everything else, but actually some of the fundamental things within the NHS, sadly, are that the IT, it does what it needs to, but actually AI looks not at today, but it looks a bit at tomorrow. And the IT within the NHS isn't fit for tomorrow, probably, in a lot of instances. So actually, that's why I think there's been a lack of adoption in some places. The few places where it's been adopted, it's been at forward-thinking trusts, hospitals that have got a slightly more forward-looking AI or IG group of people, group of staff, and they look at it slightly differently. I think where it might win in the future, and what I found, whether it was just because partly why I went to RSNA in terms of what we at Alliance are looking at, or whether it was just because that's the area of interest I have, is that in the past people have kind of focused on what I call the shiny stuff, the pixel AI, and that's been hitting the headlines. Here's your image, what can AI do to either help the radiologist or enhance the image or whatever. But actually, if you look at the whole pathway, the image is a relatively small chunk of it. It starts from the order com, or in the UK, the referral request, and it ends with the report going back to the clinician or the patient to complete that journey. And it's particular of interest, I'll have to declare my bias here with Alliance, in that a lot of the imaging we do, we are not charged with having to provide a report for those images. We do a lot of image-only services for hospitals. So actually, we aren't that interested in the shiny bit of AI that looks at the pixel. We're interested in the operational bit. So not the sort of the sexy AI, what I affectionately call the dirty AI, the stuff that lives under the hood, that's willing to roll its sleeves up and get a bit dirty and do the heavy lifting of moving images around, or doing that in a clever way, or aligning images before the radiologist gets to them so that they're hanging in the right protocol, or even further, helping you with the clinician with some clinical decision support and being clever around bookings and reducing DNAs. And I think that's the bit that suddenly people went, actually, there's a lot more to the overall radiology process than just the pixel. And they started looking wider. And as I said, the biases, that's the bit Alliance are interested in. So I went with that hat on looking for that stuff. But there was a lot more around. I was looking for that last year, and I came back kind of scratching my head going, there's not a lot here. But this time I've come back with a shopping list.
Yeah, I would agree with that statement. I would say that there are one or two vendors that I saw in that space last year, and they were really just getting started. And this year they came back with much more mature looking products around things like scheduling, not just scheduling providers, but scheduling exams and how do you manage your resources in a radiology department. Also around care coordination, so managing follow-ups for either interventional procedures or for incidental findings on imaging exams. And so I think the operational side of AI was really starting to emerge at this meeting this year. And I think there are some companies that are really coming into mature products and starting to actually pin deals with large hospital systems that show it really maturing as a subset of the AI we're seeing at the meeting.
Yeah, I find it really interesting because as we move into more of this kind of a discussion of AI, and you think about the entire diagnostic process, which you mentioned, that's actually how you can get radiologists to want to be more engaged in AI, as opposed to the eye candy kind of AI that we see, in marketing or in advertisements and so on, or the things that like capture the imagination. It's that operational component, that whole diagnostic pathway, as you mentioned, that if you can gain trust in that way, where we know we need help, it might actually help with the adoption of the other components of AI.
Yeah, I think this year was really the rise of the platform vendors as well. Not just like not the app stores where people are plugging in the diagnostic AIs, but trying to operationalize, as we're saying, the whole process. I heard words such as orchestration used a lot, platform, and then a lot of the cloud vendors saying, well, if you're going to have the platform, why is it not all in the cloud? So can you guys speak to those kind of trends and conversations?
So I think I noticed that as well. I feel like there were a lot more of the image AI vendors that were partnering with platforms in the last year and announcing those partnerships at RSNA. And you could see on the different platform vendors imagery that they put up in their booths, all of the different AI tool vendors that they had partnered with, and you'd see some of the common themes. A lot of the vendors seem to be taking this strategy. We discussed this in the pre-discussion, where they just want to partner with everybody and make sure that they are in all of the platforms, so that because right now there isn't a dominant vendor. There is no Apple App Store or Google Play Store that really is dominating the market, and so partnering with all the platforms does make a lot of sense. I would like to think that some of this has been driven forward by the attention around RSNA put on, and I've been a part of this for all 3 years that we've done it, the imaging AI and practice demonstrations, which occur right in the center of the AI showcase. The first year it was all virtual and things were there was a little bit of artistry in trying to make it look like things were really interoperable. But last year was the first time that we really got things working. And this year, the improvement in the demonstrations, which involved a variety of vendors, from platform vendors to AI tool vendors to reporting vendors, really the way they worked together to make those seamless integrations for the demonstrations was just incredible. And we had a lot of people coming to the booth this year saying, I've started asking all my vendors for this stuff now, because I think the interoperability piece is super important to making this viable in the long term.
You agreed on that side, Peter, from the Alliance take?
Yeah, absolutely. I mean, I think you're absolutely right. It was much more platform. It was very much the AI vendors were very much wanting to be on every platform, not to miss out in case you happened to buy that one and it didn't have theirs. And there was, as you say, no one quite knows which, if there will be one dominant platform, no one quite knows what that will be or what that will look like. So I think that's a sensible approach anyway. But yeah, no, absolutely. It's kind of the other slight take on it that I also saw was that even some of the enterprise or the PAX vendors were starting to think, we're already a platform. Could we be the new AI platform as well? So there are some PAX, what you would call traditional PAX vendors. Don't get me wrong, you've got the fantastic platforms that are out there that are dedicated as that for an AI model, but these guys are going, well, if you've got a platform already and we're calling it PAX, it's now on the cloud, so they've rebranded it as an enterprise. It's a platform. Could you stick some AI on it? And then there's that whole thing of, do you integrate on a sort of right click, so third party type integration, so slightly hands off, or do you actually go further and get fully embedded? So there are some we're sort of trying not to necessarily advertise, but so there are one or two PAX providers that are going the extra mile and kind of revalidating the AI for the AI company, and then saying we will make it an inherent tool. There's no right click. If it's a chest X-ray module, whatever it is, that does a pre-read, it will be built into the PAX. There won't be extra button to press. There won't be another app to fire up, and it will be fully embedded already in the workflow. And I think that's interesting as well, because then it says, well, then are you going to find PAX companies merging with platform companies, or are you going to get buyouts, as we saw with some of the smaller AI companies that were being bought up by the bigger players?
Yeah.
You know, you go back several years and there were hundreds of little AI companies, and some of those have disappeared, and some of them actually haven't disappeared. It was such a good idea they got bought out by the bigger company, and they've been amalgamated. Are we going to see the same thing again next year? Are they going to be fewer but bigger?
Well,
I'm not
this
sure.
is the next question for Peter. Like, you know, as you say, I think back in 2016 or maybe 2017, when deep learning sort of crossed that threshold, we had 100 or so tiny little startup booths, all shoved in a little corner at RSNA. But this year, there was no corner. They were just part of the main industry hall in South Hall. And some of their booths were as big as some of the big OEM vendors. And yes, there's been some consolidation across the market, some interesting acquisitions or mergers, or however you want to term it. Well, what do you guys think for next year? Do you think we're going to see more of that? Are we going to see a handful of dominant players emerge?
Yeah, I think this is part of the natural evolution of this of AI in radiology practice. And we're seeing the foundations of it. We're going to see more of it. And I think if people look at radiology practices and health systems as their customer, it's important that they do that, because it's a challenge to work in a health system where, you know, you're going for contract here, contract there, this platform here, the interoperability there. Being able to have things synthesized will help the implementation and the acquisition of these technologies in practice. So it actually behooves the industry to do this.
Yeah.
The other thing I'll mention is that it's, sorry, I'm just piggybacking on that idea a little bit. The other thing I was going to mention is that it's really a problem in the US for smaller private practices who are interested in adopting AI tools, this concept of scalability, because if they start installing, you know, one little server or gateway to a cloud environment where each little vendor is going to be managing, you know, one of the tools that they implement, that's just not scalable. It's not really scalable for me or Ella at big university hospitals, but it's definitely not scalable for small practices. When you start talking about implementing 5, 6, 15 different AI tools, it's just not going to work.
Yeah, I was going to chime in and say that even in a large academic health system, the resources that are involved to implement one after the other, the wearing down of, you know, of contracting and IT leadership to say another one, it's becoming, I think, a little too much, and we're really trying I think we really have to rethink how we're going to move forward in a way that's a little bit more synthesized, a little bit easier to adopt. IT is already a bit of an enigma, and radiology is already a big user of IT services and health systems compared to many other clinical areas. And it's only going to get more complicated, even for big systems, and more challenging if we don't start to see synthesis and integration across the industry.
Yeah, absolutely. And I think, sorry, Hugh, I was just going to say, and of course, if we're talking that the AI is moving into that more operational space, it makes sense that they then embed into whatever the existing platform is, because that's where that stuff needs to happen. You don't want that stuff plugging in and sending to cloud and receiving something back. You can have that, say, with your pixel-based AI, but some of that operational stuff or your clinical decision support to help the referrer know what is the optimal imaging or when is the optimal imaging to be done for their patient. You don't want that necessarily going outside of the inherent order-com system that you've got to help the patient entry into the pathway. So I think it's kind of got to be embedded. I think that's my view anyway.
I think there's also this other element of who uses radiology data, who uses imaging data. And obviously we think about radiology practices. We have so many specialists, but we also have the patient population. And people are interested in getting their hands on their own imaging data and sending it out for different types of analyses from different vendors that do things that maybe their practice isn't doing, to help them understand their image data better, to help them make a better diagnosis or decision or probability of disease. And I think if we don't get ahead of this as a practice in the discipline of imaging, that we're going to see more leakage of how our data is used outside radiology. Now, it's a good thing and a bad thing, because it's a good thing and it recognizes that people want to analyze their data. Specialists want to see advanced analyses of their imaging data. Patients are asking more and more questions about it. Well, did you do this? Did you do that? So it's a good problem to have, but we do have to think about that balance about making sure that we're offering great services to our patients and to our referring physicians, instead of having other people take little pieces of it that are maybe around their specialty or that are patient directed and kind of self-service, if you will.
So this RSNA 2022, marks the 5-year anniversary of Geoffrey Hinton claiming that we'll all be out of jobs. So categorically, we can now say he was wrong. We've all been saying he was wrong all along, but now we can say it categorically, right? Nods from the panel. So then the follow-on question is, what are the efficiency and value drivers of AI in radiology? And what does the future of a clinical radiologist's job look like if we imagine that these platforms are going to be, omnipresent and diagnostic AI is going to be less than a click away? What does our job look like in the future?
So
I can take a stab at it. I would say I think it'll make our job easier in many ways, because there are so many things that we do where we have to hunt and peck around to get it right. Whether it's, as Peter nicely said, this whole diagnostic process. Did we get the right information from the order? Did we protocol the exam that we're doing correctly? Did we do the right exam? The quality assurance around the actual acquisition of the imaging, and could it have been done better? And how can we do that improvement? And then our post-imaging component, the reporting process, all of those things can be made more efficient with the right information at the right time in the right place, so that there's less of that happening around the interpretation cockpit, so we can actually focus on the part that radiologists are so optimally trained for, which is looking at the images, synthesizing findings, and coming to diagnoses. I think it'll make my life a lot easier to have AI in this entire workflow integrated. And so the nuisance things can go away a little bit.
Walter.
Yeah, so I was talking to Elliot Siegel recently about this from University of Maryland and some other folks as well. And we were envisioning this, radiology AI cockpit of the future, where you're sitting and you've got your 6 or 8 screens in front of you, and you're kind of flipping back and forth between screens, and digital assistants are bringing up the relevant information for the exam, so you don't have to go digging through the chart to find all the lab values that you're looking for, to find all the relevant snippets from all the clinical notes. It all just gets brought to the fore, and maybe you have a chat GPT like agent that's running in the background, and you can say, gosh, I put this, this, and this in my differential. What else do I need to add? What have I forgotten? And the answer will come back to you quickly. But as Hugh and I have been interacting on Twitter lately around chat GPT, the current technology there just isn't quite where it needs to be for that sort of future. But hopefully in time, we'll get away from this, often wrong, but never in doubt is the saying that we use around here in the States for the type of information that's coming back from chat GPT-like agents at this point.
And will radiologists actually have a physical workstation in future? Because there was a bit of virtual and augmented reality at RSNA as well. I don't know if you guys had a chance to visit those demonstrations. And if you did, what did you think?
I remember, speaking to Elliot Siegel, I remember Elliot's kind of cockpit of the radiologist's future, almost like hanging in space with things around you. And, now we're at the stage of this, wearing 3D goggles and integrating information. I don't know if those of us who were, I remember the days of taking 2 images and then trying to get your brain to fuse them so you could get depth. So that's a bit of a throwback to several decades ago. A lot of people, I was one of them, who got such tremendous headaches from that. So I don't know if I'd be able to adapt to a lens headset kind of a way of interpreting images and data and seeing everything. But I'm really curious to see how that will come out for us in the future.
Peter or Walter, did you see any of the virtual or augmented reality futuristic demonstrations?
So before Walter comes in, I'll say that I didn't, but I think the thing that the UK would need is reliable broadband around the country. There are still parts of the country in England that don't have Wi-Fi or don't have 4G, never mind 5G. So I think there are some places where they'd be delighted if every time they plugged in their 3 screens, their server, and fired it up, they got internet. So I think we're a little bit further away from. I didn't see it, to be fair, but I think we're a little bit further away from going virtual, because I think the one thing you have to have is absolutely reliable connectivity if you start getting into that arena.
Basics first. Walter, sorry, you were interrupted.
Yeah, no, it's okay. I think that's a really good point too. One of the things that I played around with was intended for surgical planning, so you can bring up 3D rendered volume of one of your patient's imaging studies, and then you can kind of pick and manipulate it in space, spin it around, find the right angle of approach, and then slice down into that volume, kind of scroll through the images as you're simulating a sort of surgical approach. And so I think it's interesting from a surgical planning standpoint. You have it's sort of a virtual analog to 3D printing, where you can print out a structure, say it's a complex arteriovenous malformation that you're trying to figure out, where do I need to cut off the arterial supply and cut off the venous outflow. And so maybe it's some analog to that in the near term. I've seen presentations on this recently about trying to use it for interventional radiology and planning biopsy approaches. And I think there's certainly a lot of potential in that regard for virtual and augmented reality. I think, as Ella said, it's just going to be challenging for us to adapt to this idea of augmented reality, of having some separate visualization that is overlaid onto a physical patient, and trying to somehow integrate that into our own processing. It'll be a learning curve for sure, but in time, maybe we'll come to see it as natural as scrolling through a stack of images in PACS.
Could radiology be the first clinical discipline to have its own metaverse? Are we going to be attending tumor board meetings virtually, and everything's going to be done via VR, and we won't have any legs? Is this potential future?
They're hard enough over Teams.
All of us except the brain.
I joke, but that though I did see one demonstration in that regard as well. I thought that was an interesting thing to pick up on. And also, Walter, you briefly mentioned on 3D printing. That's always been in the background at RSNA. I felt there was a little more presence this year, as if people were actually starting to use it now in clinical practice. I don't know if you want to speak any more on what you think about 3D printing.
Yeah, so I would just say that I think there's a big role for it in potentially in many other areas as well, but I see it a lot in surgical planning, particularly around complex vascular malformations, in congenital heart surgery, trying to figure out how to reroute the plumbing to get things flowing as they should in cases of single ventricle type pathology. I think it's been found to be very useful in some of those arenas, but I think there's probably a limit as to the areas in which that is going to be useful in the long term. That there'll sort of be a limit at which it maybe isn't as useful. But one of the ideas that is out there that I haven't quite wrapped my head around yet with 3D printing is actually 3D printing of custom-made medical devices and tailored to the size and shape of the patient or the anatomy that they're being implanted in. I think that is a really promising idea for the future of 3D printing, and that some of the tools that or some of the applications, use cases that we're currently using 3D printing for may end up shifting into more of the VR, virtual reality, augmented reality space over time, but that 3D printing itself may become very useful for custom implants.
Yeah, it's something to definitely watch out for in the future, isn't it?
I was going to say one thing with respect to 3D printing that's been very interesting over this last couple of years of the COVID pandemic is because we've had supply chain disruptions, is using 3D printing to create things that we would normally get through a commercial vendor to do our work, and needing to find short-term ways of doing things. Everything from one example we had was a grid that's used in breast MRI to guide breast biopsies. Well, when there's a supply chain shortage and now you don't have any way to provide that great level of patient care, to be able to work with people to develop something like that so you can maintain your clinical practice. So it's taken on some other new roles because of supply chain shortage, as well as the great things that Walter said. Certainly the complex three-dimensional anatomy, surgical planning, and patient education as well.
Yeah. It's definitely something to keep an eye out, I think, for the future. So to the audience members who are sending in questions, keep them coming in. We will get around to having a look at some of your questions near the end of the session. I've still got a few more topics to pick our panelists' brains with. I wanted to sort of shift now back to the clinical uses of AI. So these single point algorithms, the ones that the FDA will class as CAD-T for triage, CAD-E for decision support, or CAD-X for automated diagnosis. Did we see any particular increase in new use cases this year at RSNA, or do we think all the use cases that AI could be applied to have now been found and someone has built an algorithm?
Well, one of the things I found interesting was, a tool that claims to be able to identify, I think it was over 120 things in a chest X-ray. Are there only 120 things to find in a chest X-ray? I never sat down and counted. And there's also a lot of questions behind something like that. But I don't think we've reached the limit of everything that can be found. But it seems like, it won't take too long to get there.
We know how to build them now, don't we, Walter?
Yes, indeed. So, that's one of the things, is that if you have an AI application that you want to build, that there's certainly a pretty straightforward path to doing so. I think one of the problems with building a tool like that detects 120 different findings is having enough well-labeled imaging to create a model that can perform sufficiently well. It's easier to imagine being able to do something for for plain radiography, chest radiography, fracture detection. But when you start thinking about cross-sectional imaging, chest CT, brain MRI, etc., that you start getting into a whole nother level in terms of complexity when you have multiple different sequences to integrate, or multiple phases of contrast to integrate into a single model, and then getting all of that, well annotated, well labeled for particular applications. I think it's just a challenge of tractability and having high enough quality data or intelligent enough solutions to tackle that problem. But as far as, have we covered all the use cases for AI and radiology for pixel data or image analysis? I don't think we have. I think part of that is just that we don't have enough well-labeled data or publicly available data sets for developing these tools. And some of the ones that are available are sort of locked down under non-commercial licenses, and so that limits the ability to use those for development of commercial tools. But I think, what I noticed this year in the vendor space is that there seems to be a lot more interest in tapping into the types of payments that have come available in the last year or two. So you saw a lot of folks that hadn't really been in the stroke AI space that are now getting into large vessel occlusion detection or clot detection for potential intervention, clot removal. And I think that as we go forward and we start to see more payments emerge, particularly in the US, but elsewhere, that will drive the market in a lot of ways towards what people are developing. And if they're not developing it, the larger companies are going to be licensing with smaller companies to use their technology and potentially buying them out as well, driving some of that consolidation we talked about earlier.
So let's assume a future in which we've now got an AI for every single radiological finding that anyone can imagine. And then we're going to integrate that, as we discussed earlier, via some kind of platform. What I'm interested in is, are we discussing enough? How are we supposed to monitor all this? How are we supposed to spot when it gets it wrong? Who do we report that to? How do we correct that? The governance around it. Were there any trends from this conference of people starting to speak about that? Or do you think we're just sort of coming to that understanding that this is the next step?
This topic is incredibly near and dear to my heart. So I might let the others answer first, and then I'll chime in afterwards.
Peter, Ella?
Yeah, no, absolutely. I think you're right. It's a complex subject, if nothing else, which is, I think, what you were alluding to. And I think the other thing with it is that the pixel AI stuff that is potentially driving diagnosis is the bit that gets the most complicated at sort of ethical level, governance level, monitoring level, everything. And I think also that is potentially why more and more companies have gone after some of the operational AI. Because if you're just looking at booking appointments and the AI gets that wrong, you've got frustrated patients, but you haven't, to be blunt, killed anybody. I'm not suggesting that happens very often anyway, but the point is, if you've got an AI that's looking at a pixel and it says it is this diagnosis or that one, that could be a significant difference in the treatment shift for that patient, that have consequences, complications, etc., that could slightly further down the road lead to adverse outcomes. So I think that's the other part of the reason for the shift, probably, is that people have looked at this and gone, there is a big piece still to work out, probably truly, around the ethics, around the governance, around the monitoring, to think of AI as a medicine that has to be looked at and monitored in that way. But some of the operational stuff is kind of doesn't have those parameters to it or those issues around it, because if it gets it wrong and it's a booking system, so maybe you've got a few empty slots on your CT scanner for the day, there's worse things that can happen. Okay, you're losing money and all the rest of it, or if you're less efficient with a scanner, as opposed to being more efficient with it, there can be unintended consequences, but they're not significant from an outcome of health point of view typically.
Yeah,
and I think that's the
what you're describing is in essence the difference between a regulated medical device, which has a clinical intended medical outcome purpose, versus just health software, which yes needs to be cyber secure and all of that, but it doesn't have that necessarily that clinical adverse event potential.
And I think a way to put it in context is if you have a tool, and let's say that it does what's supposed to do 98% of the time, and you're using it in your scheduling software as part of your operations, and what you're overall seeing is an improvement in efficiency, less FTEs needed for the process. You see it as an operational tool generally working. And if a couple patients get in the wrong grid, or a slot remains empty, as Peter said, the overall performance in your scheduling system is still up, and your workflow and your patients in your system should be improved. You take 2 catastrophic failures to detect, and it is a very different story. And so I heard a lot more conversations amongst people about the catastrophic failure to detect, the catastrophic miss. And that becomes then a level of trust, that is what creates the level of mistrust about reliance and dependence. And I do hear people as they do a lot of work with lung cancer screening and incidental lung nodules around, in the US and around the world, working with colleagues, we hear about things like under-resourced countries perhaps using AI tools to help because they have a lack of radiologists or a lack of specially trained radiologists. And it kind of all depends on where you're using it and why you're using it. If I were to use a tool perhaps in my practice where we have all specialized thoracic radiologists and have a 2% failure to detect rate, it would be catastrophic in our practice. But if you're using that same tool in a venue where you simply don't have people to do the work and you can't even get the patient seen, you're going to put it in a different context. So context is really important to the use case.
And now for Walter.
Yeah. So, we've covered so much territory already. I'm kind of having to backpedal in my mind, trying to figure out where to start. So, let me walk backwards into it. So, I'm going to say that I agree with Ella that I think it all depends on the setting in which the tool is applied. That your thresholds are going to be different based on the perceived risk. So, if you're talking about analyzing chest radiographs or some other imaging study that's never going to get looked at by a radiologist, then your bar for what is catastrophic failure of that tool to detect something is going to be different inherently than on the types of studies that everybody is going to be looking at, or perhaps like mammography in certain settings are going to be double red. And so I think taking a step back and looking at the bigger picture, and thinking about what we saw at RSNA this year, I think a lot more people are talking about where AI goes wrong, how to decide about these things like governance and what needs to be done on the regulatory side of things. But some of those processes move slow. So we've seen, the FDA kind of very slowly moving towards this idea of the total product life cycle and really ramping up the requirements for post-market surveillance of software as a medical device. But if you ask the vendors right now, are they building it? No, because customers aren't asking for it and the FDA is not yet requiring it. So there's no economic incentive for them to do it yet. So really it comes down to institutions and practices to decide how they want to develop governance around this. And so some colleagues of mine and I at Duke, Stanford, and Mass General Brigham put out a paper in radiology this past year talking about some of the ways that we do things. I don't think that should be seen as a best practice necessarily. It's more of an expose of what we've tried in our early experience and the things that we're still working on and still trying to develop around what kind of monitoring is required. A lot of what we use at Duke is based off of the IMDRF risk stratification table, where you look at the state that the patient is in when the tool is being applied and the effect of the tool on the diagnostic decision making. Is it fully autonomous, or is it aiding in treatment decision making, or is it just aiding in diagnosis? And with that decrease in autonomy or decrease in influence on the patient's final outcome, goes a decrease in risk that lowers the bar for evaluation. But what we've decided at Duke recently, originally we thought, FDA cleared tools rather than locally developed or externally developed but not FDA cleared yet, probably FDA cleared tools could go through a more fast track governance process around deciding how to implement them and how to monitor them. But recently we've realized that we've seen some FDA cleared tools where they are not performing as expected, and so we have to be a little more cautious when approaching those tools and really give them the benefit of, or benefit in our terms, of full review when it comes to making those decisions.
So do you think that the FDA has been a little trigger happy in allowing, I think it's 96 or just over 100 510K approvals this year for radiology AI algorithms, which are just saying these are based on some predicate AI algorithm that was passed 5 years ago? Is the FDA being a bit trigger happy? And is this leading to a slight distrust of the diagnostic AI systems out there?
I think they're responding to the concerns that are out there from the community that's raising the concerns. And sometimes, what's the quote? You have to go slow to go fast. And I think that is probably prudent in that space.
Yeah, they say that regulations are written in blood, so they'll only change once adverse harm actually starts to happen to patients. And that brings me nicely onto my next topic. Are we ready for fully automated AI diagnostics? And this might be for single points, or it might be whole image based, but there are a couple of vendors who are claiming that they can do diagnosis. Do we think radiologists trust these systems yet? Is the evidence there? And what are the risks?
I'm going to go with a resounding no. Helpful, but resounding no.
Peter?
I was going to do the same, to be fair. I was going to come in and go that we're not there yet and leave it at that, effectively.
So, Walter, where would a fully autonomous diagnostic system fit in that IMDRF risk matrix that you described?
Well, it depends on what you're diagnosing, but it would certainly be in a much higher risk category just because it's fully autonomous, regardless of the situation that the patient is in. As long as it's being used for diagnostic purposes, it would already be at a level at which our governance committee would consider it for full review. I think the more challenging question is, how do we get there? How do we get to a point where we're ready for that? What is it going to take? And I think, from my perspective, having automated or semi-automated tools that can run in the background to monitor the tools that we have deployed now is going to be a step in the right direction, because that will show us the path towards monitoring these tools once they become fully autonomous and are running. And I think you may end up seeing a day where, when these tools are deployed, instead of the way we do peer learning or quality assurance in the US, is you kind of get assemble a batch of cases where there's been a mistake in the peer learning paradigm, or in the QA paradigm. You may just get assigned a random batch of 25 or 50 cases to review periodically. And I think we may end up seeing a day where that happens for the AI tools, where you have an AI tool that's running, and periodically you assign a radiologist to review 25 or 50 of the recent cases that it has made a diagnosis on, to see how it's performing in the real world. But that alone isn't going to be enough. I think we do need those tools running in the background to monitor deployed AI tools and be able to track their performance over time.
And this leads nicely on to the last question before we get on to the audience questions. Then, people have been talking about AI bias for a long, long time. Did this year's RSNA help us get closer to the answer of how we solve the issues around AI bias? Or is it still a problem that we don't know how to address? All
right, I'll throw in a thought here. So as recently as a year or two ago, I think we thought that if you just put together a diverse enough data set that had all populations or demographics represented, that would be enough to train a tool that's unbiased. But this gets back to the idea of the three meetings running in parallel. While I was attending more of the vendor side of the meeting, there was a scientific session that I heard about later where someone, and I can't point to who, but someone presented results that showed that that's not enough. That even despite putting together a diverse data set and training an AI model on that first diverse data set, they were unable to combat the bias. So I think it comes to more, it's a twofold approach. It's designing better models and being able to monitor for bias, flag it, and potentially intervene when it occurs, or know how to handle it. And so on the development side, data sets aren't enough. So we have to move into more active strategies. Some of the ones that have been thrown out there are, adversarial debiasing, where you basically challenge the model or penalize the model for bias, challenge it to be less biased. There are certainly other strategies as well, but I think until we get there and have less biased models, we get back to my favorite platform to stand on and speak loudly about is the monitoring aspect. And so there you go. That's my take.
Yeah, it's interesting because bias exists in pretty much everything we do in healthcare, and it has for a very long time. And it also exists, and it exists culturally. It exists in research. And it's interesting because of the COVID pandemic and the increased visibility of some types of bias, that AI has coming, the development and acceleration of AI is coming about at a time where these recognizing biases, gender, racial biases in the way we practice medicine are coming together at a point where AI is being asked to do something relatively at its infancy that we haven't done a good job in healthcare in general. And so it's actually a plus for AI to be addressing this head on now in the way these things are developed to move forward, because we're still trying to figure it out across the breadth of healthcare.
Yeah, so I think it's going to be one of the big sticking points, and I agree with Walter that the post-market monitoring is going to be one of the next big topics of discussion. I think maybe at RSNA 23, people will show us some solutions of how to do that in best practice. I'm going to move on now to some of the audience questions. The first one, I think I'm going to give it to Peter. Was RSNA this year complicated by the fact that the World Cup was on at the same time?
Yes.
Football fan, Peter?
Yes. Simple. Next. Yeah, I mean, I was at one point torn, where I had some colleagues messaging me, peeling off, saying we are in a taxi heading to a sports bar because the America game was being shown in the halls, but England were playing at the same time, so not unreasonably it wasn't being shown, and they were heading out to find a suitable bar to watch it in, and I kind of went, yeah, I've got more appointments in the exhibition space. I'm afraid I'm going to just have to keep going, and the football had to come second. But so it was definitely complicated.
I did notice the Americans immediately lost interest in the World Cup as soon as America were out, and England carried on. It was very hard to find a television screen showing the English games. Anyway, that was a side distraction.
Following the Morocco story closely, so watching them as the underdogs getting to the semifinals was pretty exciting. So
they are doing well.
We're quite a soccer or football household here, so we constantly have the World Cup games on, and we're flipping back and forth, and we're arguing about this player and that player and which team and what team. So it's actually been really exciting, and actually have some of the games on at RSNA added to a lot of camaraderie and people standing around talking about things. And it was also very interesting to talk with colleagues from around the world whose countries were participating. So I thought it added a really nice element.
It did.
I think the vendors who had I think the vendors who had the TV screens up showing some of the games that were on were really smart, because it probably increased the traffic at their booths.
Indeed.
And without wishing to be too controversial about the football, what interestingly for me didn't come up was the whole dilemma about LGBTQT plus and it being in Qatar and that whole aspect. That was the one thing for me that interestingly wasn't touched on at all. People were kind of accepting that it was happening, it was on, and it's just speaking personally, I'm conflicted in terms of, on the one hand, I think Qatar should never have had the World Cup. On the flip side, the players are professional athletes, have trained for it. Do you really want to take that away from them? I'm not saying I've got an answer, I don't, but it was interesting for me that conflict, I'm not saying we get into it now, but that conflict wasn't touched upon. It was much more around the let's accept it's on and kind of get on with the fact that who are you supporting, or if the home team is out, who do you follow Morocco now? Do you that whole that and there was a camaraderie around it for sure.
Yeah, indeed. Another question now, moving on, a bit more serious than the World Cup. Privacy takes a play in the operational part as well, and they have said this to you, Peter. What's your take on the privacy aspects on the operational side of the AI tools?
Yeah, well, I mean, we're in the UK. We've got GDPR. We're at least as well regulated as anybody else probably in the world around protecting patient data and all of that kind of security. It's sometimes why we have older legacy systems in the NHS, because the IT staff in the NHS think that Windows 95 is more secure than Windows 10. There is one piece of hardware I know that is running Windows 95, by the way. I won't tell you where to embarrass the site. But so it's definitely a factor and always a consideration. But I think on the whole, it's controlled for, I'd like to say, quite well, usually. And again, if you're talking about some of the AI that's embedded in the wider process, you're kind of there's no external visibility. It all kind of stays in the system if it's all in one place. I think it's different if it's heading off into clouds, and then that takes on a whole different view. But I think if it's all embedded within the sort of the one single platform, for want of a better word, or the one single solution, then I think that's less of an issue, because it's then all in that space under the bonnet, and nothing is leaving that space. Maybe that's too simplistic an answer.
Yeah, I will say that there's a tremendous diversity of perspectives on the privacy issue, and there are very conservative opinions in institutions and people making decisions who have a very low tolerance for any leak of any kind, and others who are on the other end of the bell curve and talk about without being able to share data to be able to advance the field, it's necessary. But we have seen, I think, a lot of challenges with the ability to share data for the purposes of development. We've seen large health systems, mine being one of them, put very clear restrictions on what you can do with patient data, and under what circumstances you can send data out. And even in a tool that we have worked actually several years to get integrated into our practice, probably 3 years it took. It was the first tool that we installed that was going to go out through the cloud and to the cloud. And it took a lot of time to be able to move the institution forward to accept that type of a model. I hope that first time through will lay the groundwork for the future, but it just speaks to the level of concern that large institutions have around risk and patient data and privacy.
So the Cancer Imaging Archive, which is one of the largest repositories of medical imaging data that's out there, recently made a move to really, really discourage restrictions on licensing and access for data sets that they accept into the repository. I won't speak on their behalf as to what their official policy is, but I know that it's getting harder for institutions like Duke, Michigan, UCSF in the United States who want to put those non-commercial, non-derivative type restrictions on the licenses that go along with data that gets released into these repositories. It's getting much harder for them to find a home for that because the platforms that host the data and indeed the NIH policy for data sharing around NIH funded studies is becoming more liberal as well. And in the interest of trying to make science reproducible and in the interest of trying to maximize the public good that comes from release of such data sets, they are moving towards more open, freely accessible data repositories in general, and the TCIA seems to be following that lead, and I think we'll see others follow it too. So while privacy and data security are big concerns at institutions, I think the more that we can figure out ways to de-identify, if not anonymize data and release it and share it, the more good that will come of that.
There's a question that's come in for Ella specifically. It says, how does AI enhance the ability for radiologists to do a better job other than flagging the most urgent scans?
So as a thoracic radiologist, one of the things, for example, that is, key to our interpretation of CTs is identifying potential lung nodules, measuring nodules, looking at growth rate of nodules and probability of malignancy. And this is a very, very, very common thing on CT chest exams. And it's also one of the areas in thoracic radiology that is the most highly litigious: failure to diagnose lung cancer, to miss lung cancer, to not identify growth, to not even identify the nodule. And then many other things like communicating with referring physicians and making sure they come back for the follow-up test that they needed. That entire pathway can really be enhanced by AI. So helping the radiologist to make sure that they're doing a good job looking for these nodules. When you get a chest CT scan of 1 millimeter slices through the entire chest, which is beautiful resolution and allows you to really well characterize each and every nodule and every anatomic structure, you have fatigue. We know that radiologists towards the end of the day are definitely a little bit more fatigued in the way they practice them during the day. We know that in the morning, we know that there are pressures in throughput and that there's shortage of radiologists and patient volumes are up. So as a radiology practice, as a chest radiologist, helping me do a good job identifying, characterizing, determine the probability of malignancy and growth rate helps me do a better job with more efficiency than looking at large stacks of 1 millimeter images and MIP images all by myself. But importantly, the tools to be able to make sure, the workflow tools, that patients do come back for those follow-up tests to make sure these things aren't growing. Right now, we have these kind of complicated systems where we have people and data work streams that are clunky, and AI could really help us in the workflow, working with patients and referring physicians to make sure that people do come back, that people don't fall through the cracks. So I see it as a tremendous value.
Walter, is there a preferred use case that you've maybe used or you're excited to use?
So as a neuroradiologist, follow-up of brain metastases is a particular interest of mine in the AI space, and that's because it used to be that if you got above a certain number, say, in the early days, maybe it was 5, later it was 13, then now there's not really a limit on what some radiation oncologists are willing to tackle with stereotactic radiosurgery, which is where they go in and with radiation zap each and every one of those individual metastases, as opposed to sending the patient on to whole brain radiation therapy. They're finding that they get better local control of metastatic disease this way, and even targeting up to 40 or 50 lesions in an individual session, they're able to minimize the side effects associated with that radiation relative to whole brain radiation therapy. And so I think, for me personally, I don't want to sit there and have to put an arrow on every one of those 40 or 50 metastases. That just takes a ton of time and effort to track them down. But importantly, if one of those, and the radiation oncologists don't want to do it either, And so, but importantly, that, you know, if you miss one of those, then you're going to have to bring back the patient for another session, or maybe they do get to the point where they have to go for resective surgery or something else, and that stereotactic radiosurgery isn't going to be enough. So I think, you know, every specialty can probably come up with a use case like that where you have something that is just absolutely tedious. And if AI could help you get past that, it would save a lot of mental energy for more complicated tasks, like trying to figure out, you know, whether or not there's, you know, perineural spread in the head and neck, or some other such task that a radiologist could perform that requires more of our cognitive effort, and rightfully so.
And Peter, I know you said you weren't so interested in the clinical use cases, but is there a use case that has got your interest?
Yeah, for sure. I mean, we do lung health checks as Alliance Medical in the UK, and we use an AI tool for looking at the low dose CT chests, specifically for that reason. We've shown it speeds up the radiologist as well, that they're quicker. And as you say, the key thing is the threshold setting, that if anything, it's oversensitive, and you can then go and click on it and say, no, it isn't a nodule, it's an amalgamation of vessels or whatever it is, and dismiss them, or you keep them all in. And the nice thing is that similarly, those sorts of tools can have nodule tracking on them. So when the patient comes for the follow-up, it tracks all of those nodules across the scans. We were talking about, are we going to run out of AI cases? Well, the one area where AI hasn't veered too much in that sense is in the SPECT and the PET CT space. And Alliance are the biggest provider of PET CT in the UK. We're doing about 115,000 scans a year. And there's not a lot of AI in PET CT. It's starting to be, in the same way that you can trace around a nodule, you can trace around an area of increased uptake around the hotspots. And again, you track the hotspots. Are they responding? What's the gross tumor volume? And all of that could be done with AI. It isn't being done with AI. It's being done with me. And later this evening, I shall be doing that on some of those lymphoma studies that are waiting for me to report. But I'd love it if AI did it for me, and it made me slightly more efficient. There's lots of, it's that kind of, it's the monotonous stuff, isn't it? That's also safer. That's also less around a true diagnosis. But it's heavy lifting stuff that just takes time. And it's also, back to your point, Ella, you said not only, you're right, do we get tired at the end of a shift or the end of a day, but actually this stuff is tiring. So it's taking some of the more tiring tasks away from you. And if it leaves you with the slightly more stimulating stuff of, actually, what do all these nodules mean? Well, that kind of wakes you up again and goes, right, I've got to go through my differential diagnoses. Now, if the AI is also suggesting, if you've got a chat bot saying, hey, have you thought of this? Have you thought of that? Have you got every occupational disease that you can think of that's relevant because the patient lives over here, by the way, and it all starts to link up, we're getting distracted again. But, there's some of that also for me is a relatively safe space for AI to play in that still leaves me as the doctor to do the cleverer bit, if that's the right way of putting it. But I mean, if there's anybody listening and they're bored and they want to build some AI, please try some in PET CT. We'd be very grateful.
Yeah, we haven't seen anything in PET CT. I've not seen anything in abdominal or bowel imaging much. I've seen a few helping with 3D, colonoscopies, but I've not seen anything like looking for small bowel fistulae or anything.
There's
like
a few bits in PET CT. You must have missed our presentation that we did with the Leeds group on AI in PET CT. So it's fine. But it's starting, and like all these things, it's kind of, everyone went for X-rays. They're moving into CT. MR is complicated because of multiple sequences going over the same anatomy with different signal intensity and all the rest of it. And then PET seems to be further down that line. But we're starting to play in that space. I'm sure there are others, but it's untapped at the minute.
So that leads on to the next question from the audience. They say they think one of the cool things happening is risk scores. Radiology is creating new biomarkers. So what do the panel think about not producing a diagnosis for a single pathology, but providing a risk score for a disease or a condition?
That feeds directly to what I was talking about lung nodules. That's one of those integral things that's happening in the early detection of lung cancer space. And, I'd be remiss if I didn't say that Duke, for example, did a really good study of incidental findings over a year, and 40% of their actual incidental findings are lung nodules. And lung cancer is the leading cause of cancer death. And we know that we can find as many lung cancers or more through all the CTs we do outside of screening than we can inside screening. So when we find those nodules, what's actionable, what needs follow-up is driven historically by Flagship Society guidelines. But we know there's a lot more things in the images besides the size and the density of the nodule that can drive that probability of cancer. There's other features besides its solid or ground glass, its margins, its contours, the emphysema around it, the lung context, if you will. And there are other things even in the image that show that a patient has a lot of, for example, smoking-related organ damage in their coronary artery. So if you can start to use other information and bone mineral density as well, you can start to use all of those things around the nodule to drive the probability of cancer and use radiomics, then now you have provided a better value back to the referring physician instead of what we do now, which is basically size, density, follow-up in a certain time frame. And I think we can do better in the future.
So one of my colleagues at Duke, Dr. Kirti Magudia, has worked on a lot CT body composition analysis, where you take, depending on the approach, you take a look at a slice from an abdominal CT or even a volume from an abdominal CT and look at the relative ratio of subcutaneous fat to visceral fat to skeletal muscle. And with some of those metrics normalized for age and biologic sex, you can come up with predictive scores for morbidity and mortality associated with cardiovascular disease, with pancreatic cancer treatment, with thoracic surgery, getting back to the lung cancer idea, these patients who have to go through what end up being, very physiologically stressful events of having, a chunk of their lung removed or an entire lung removed. And so that idea of taking information that we normally don't give much thought to in our diagnosis or interpretation and diagnosis of imaging, and being able to derive useful treatment and prognostic information for patients, I think is really exciting. We're actually looking at doing that in the context of spinal surgery at Duke as well. So that's something in the pipeline that we're thinking about and actively working on.
That really helps. I mean, it also kind of gets into the concept of radiologists as population health specialists. We think of ourselves as diagnosticians within a certain symptom or a certain finding or disease state, but there's so much information within imaging that can provide predictive ability about somebody's future risks of cardiac events, cardiovascular events, stroke, compression fractures in their spine, which if you have lung disease is going to increase your risk of pneumonia. So there's a lot more to what you said, that there's a lot more information in the images that right now it's very hard for radiologists to go about measuring and looking at each and everything and manually do it. That seems like something that AI could easily serve up to us as radiology practitioners as a population health component of what we do.
I'm going to move on to the last question now on my list here from the audience. Is for Walter. Where is your particular focus on the clinical implementation of AI technologies in medical imaging? And what about risk management? Are you focused on that? I think the answer is
very much. Yeah, very much so. So my particular focus right now is on making sure that we have the right infrastructure for making our implementation of these tools scalable. And part of that is having infrastructure for capturing metadata around the types of exams that are being acquired, what the acquisition parameters are, how that aligns with the vendor specifications for each of our AI tools as to what acquisition parameters should be. Because in a large health system such as Duke, where we incorporate multiple hospitals and many outpatient imaging centers into one entity from an IT perspective and a protocol management perspective, there's a lot of variance across our different imaging sites as to how different images are acquired, and even, per diem technologists coming in who may not be familiar with all of our manuals and potentially playing around with acquisition parameters, either, with good intent to try to expedite the acquisition or to improve the image quality, but potentially getting us outside of those parameters that we need for the AI tools to function properly. So that's part of our monitoring approach. And then the other side of it is trying to develop tools for semi-automated or even automated monitoring of how these tools are performing over time, so we can try to signal a problem before it reaches a patient. And then alongside that is sort of using the radiologist as the canary in the coal mine. So one thing we're rolling out, hopefully in the first quarter of next year, is the automated or very easy integrated into the workflow button for just signaling a potential problem with an AI tool, and an optional comment box for saying what exactly you think went wrong, trying to reduce the lift for radiologists providing feedback to our clinical AI team and IT and informatics team as to, something's not performing the way I think it should. Let's take a look into this. And if we get enough of those flags, we'll certainly have to go through a model review process. So some of this is happening at a governance level. Some of it's happening at an informatics and IT level. And that really is what consumes most of my time when I'm not actually reading scans or doing procedures these days.
Fantastic. So thank you all to you three. We could go on for hours talking about it, but we have to end it somewhere. I think in some way we've all agreed that RSNA 22 was one of the best in the recent years, had the most energy, certainly more attendance in the past couple of years. And assuming there's no pandemic or nuclear war between now and next year's RSNA, are we expecting it to be even bigger and better next year? Is that the general consensus? I think I see nods. I'm very much looking forward to it as well. The AI sector definitely has matured. It's gone from a handful of startups to some big, respectable and mature players. The conversations are advancing in all directions, especially towards platformization, into the cloud, and how do we monitor this, as Walter just said? How do we follow it up and keep it within its guide rails? And the future is still bright, I think, and I think we all agree that AI in radiology is here to stay now, isn't it? It is indeed.
One way or another.
One way or another, it is here to stay. So thank you very much. Thank you to the host Qure as well for hosting the platform today. If you've enjoyed this session, this is part of a series. There'll be monthly webinars ongoing, so keep an eye out on their social media channels to find out when the next one is. But for now, thank you to Peter, Walter, and Ella, and enjoy your weekends. Take care.